Okay. Good afternoon, everyone, and thanks for hanging in there with us. I've been asked to talk about gait and orthoses, and as you know, orthoses are braces which are used to maintain joints in positions that lead to increased function or stability. The reason that I'm giving this talk is because gait is often involved in individuals with transverse myelitis, and there's oftentimes some questions about how can we work with our therapists to make the walking better that we have, and what kind of devices might aid to leading to a more stable gait or a more efficient, less energy-consuming gait. I'm going to spend most of the time talking about how physicians and therapists look at gait and how we analyze it, rather than on the specific devices that are used to enhance one's gait ability. The reason for this is I'd like you to take some of these principles back with you to your home areas and talk about things that you could try out with the therapist, because a lot of times it's trial and error with respect to which kind of braces are going to work best for an individual person. But if you have a good understanding what the underlying principles are, I think you can discuss the options better with your therapist and with your physicians. Let's start with the causes of abnormal gait. These are four common causes: structural abnormalities, such as joint deformities, pain for various reasons, neurological deficits, which is primary cause in transverse myelitis, which leads to some of these other things, and muscle group weakness. So these can be seen as four different causes of abnormal gait, but also once you get one of these things, the other things may also follow. When I see a patient come in and the question becomes what kind of brace would most help that individual, or tell me about the gait, what's wrong with the gait, I like to think about it as, well, what are the three functional things that someone needs to do to be able to walk? So the first one, or the first thing that I look for, is how is that leading limb accepting weight? What's the weight acceptance pattern? How is the foot joint articulating or moving with the floor and with the thigh? And what kind of loading forces are going onto that foot? So that's the first thing that I look for. The second thing is when the person is walking and they put all their weight on one foot to swing the other leg through, are there any problems with single limb support? And single limb support is important to advance your body forward and also to take the weight off the leg that you're going to be swinging forward or moving forward. And the third functional task that I look at is swing limb advancement. How does that individual bring that leg forward that they're swinging to make the next step? And the things that you worry about there is how do they clear the foot as they swing the leg forward, and then how do they position that swing limb in space to take the next step. When we analyze gait, we think of basically two phases: the stance phase of gait and the swing phase of gait. Stance phase is the amount of time that's spent bearing weight on the foot on that one side. On the limb on that one side. So in this diagram, if you just look at the right leg, that right leg is going through one cycle of stance. There's the phase of initial contact where the heel hits the ground. There's the loading response, which is as the whole foot comes down. There's mid stance, terminal stance, and then push off or final stance. So these are the ways we break down how the leg works during the stance phase of gait. Another refinement is to look specifically at the ankle during stance phase, and this is broken up into three phases, or 3 foot rockers. The first, and they're called rockers because of the image of the foot rocking forward. The first and second phases, or the first and second rockers, are called deceleration rockers, where the body is subconsciously slowing itself down so that these muscles are acting as brakes, the ones that work on the leg. And that's called an eccentric contraction. The third rocker, in contrast, is an acceleration rocker, where you're generating positive energy to push off and to propel the person forward. After the stance phase of gait, then there's the swing phase, where the task is to bring that leg through, swing it forward so that you can start the next gait cycle. And this swing phase of gait is controlled by 2 muscles, the rectus femoris, or the quadriceps muscle, in front of the thigh, and the hamstring muscles in back of the thigh. These 2 muscles act in coordination to control the position of the leg as you're moving it forward. So I'm going to briefly go through these 3 functional tasks and talk a little bit about each one. Let's start with the first one, weight acceptance. The critical factors are, in terms of the usual gait pattern, heel contact first. So it's important to look at where the foot's coming down, and if you can stimulate heel contact as the initial part of weight acceptance, that's going to lead to a more stable, energy-efficient gait pattern. And then controlled knee and ankle motion with hip stability is important, because at that point you want to be able to progress to the next stage of gait, where you're putting all your weight on the single limb. So you have to be able to control the forces around the ankle during the weight acceptance phase. Next comes single limb support. And the critical factors here are a controlled ankle rocker, basically bringing the body weight from the hind foot or in back of the foot forward through this first, second, and third stage of first, second, and third rockers, so that the momentum of the body continues to move forward. And that has to be and that works most efficiently if the muscles that control the movement of the tibia, which is your lower foot, over the ankle, is in a controlled deceleration first and then acceleration fashion. So there's a lot of muscle interplay here in terms of what's contracting when and how fast or how slow these muscles are working together. And then you need to be able to lock your ankle, locked ankle, heel rise, and controlling the trailing limb are also factors that are involved with a stable single limb support during the mid-stance phase of gait. And then the third phase is swing limb advancement. And the critical factors here are you've got to be able to slightly bend your knee at the beginning of the phase when you're going to swing that one leg forward to then take the next step. So you passively will tend to flex your leg first, follow with hip and knee flexion so that you can get that leg ready to swing through to take the next step. And then extend the knee so that you can take a nice big step and go forward. So these are 3 critical things that are involved with swing limb advancement. So that's a pretty quick trip through some of the things that we think about when we're looking at somebody walk and trying to figure out, well, what could be going wrong and what could be accounting for the difficulty that this person's having with their gait pattern. Or if there's something wrong with their braces, what kind of factors might be accounting for that. So you specifically will look at weight acceptance, single limb support, limb advancement. That's sort of my mantra as I watch the kids walk up and down the examination hallway. And then I think about what are some of the muscle forces related to spasticity or coordination of muscles that could be causing problems in these three areas. You can just substitute any age patient for child in these slides because it doesn't matter how old you are. But some of the principles for treating a patient with a motor disability one is to define the end product and the long-range objectives. And this sounds so obvious, but I think that we have to be very cognizant about, why are we intervening? What kind of therapeutic goals do we have? Are we really going to be helping the patient with our recommendations? Identify the patient's problems with precision, and we're going to talk about that in just a second. The eyes are pretty good at picking up abnormalities in gait and coordination, and you get better with practice. But there are some devices now that give us more quantitative measures and can look at things which the eyes can't pick up. We demonstrated one of those devices yesterday, which is called the GAITRite system, and it's something that we've just started to use at the Kennedy Krieger Institute, and we're hoping that this will be a good clinical tool because one, it's portable and it's fairly easy to use, but two, it gives us additional information that we can compare from visit to visit in terms of how are our interventions or our treatments. Let's say some of these oral medications that you've heard talked about earlier, how are these interventions, both for spasticity management and for neuroprotection or regeneration, affecting one of the most important functional deficits that individuals with transverse myelitis have, which would be difficulty ambulating. So the more precise we can be with our analysis of the gait, I think the more we will know about the effects of our treatments. Analyze growth effects with and without treatment, and again, this is probably more pertinent toward children. Consider valid treatment alternatives. We should look at different therapeutic options when we're thinking about treating someone with a motor disability, and then treat the whole person. In other words, find out about what their daily lives are like, what kind of things do they want to be able to do. I think Dr. de la Tour's comment the other day that she saw this gentleman who had figured out a perfectly acceptable way to walk with his I think it was his single point cane, although it wouldn't have been the usually recommended technique, was working fine for him, so why change something like that that was working well? And he actually had come in for some other reason, as she said. So the lesions of transverse myelitis in terms of motor disability results in increased muscle tone, and this is the spasticity that we talked about yesterday. Muscle contracture with growth or with time is possible. Loss of selective motor control, in other words, the ability of the brain and central nervous system to tell your muscles which are needed for walking when to contract and when to relax. This coordination is lost. Ambulation, as a result, ambulation will often occur due to reflex patterns that may not be the patterns that the individual wants to use at a given time, and difficulties with the balance. So there are multiple factors that will impact the therapeutic choices in terms of what kind of interventions or braces to use. And it's not one thing, it's multiple things that are going on simultaneously that affect someone's gait. So to help with the analysis, we're going to start using this GAITRite system, and I thought it might be interesting to kind of go through what the GAITRite system is. And for those of you that didn't see it, it's a electronic walkway that contains 6 sensor pads which are in a roll-up carpet. It provides an active area of about 2 feet wide and anywhere from 12 or 14 feet long, and it contains in the standard setup, this is a very sensitive switch, in the standard setup about 13,000 sensors. And as an individual walks down this walkway, it automatically collects information about steps, step length, how fast you're walking, how wide your gait is. So you can see from this slide, looks like the left feet are teal and the right ones are purple. And then if you look at those footsteps using another option in the program, it can divide where the pressure. Okay, this thing is now on automatic pilot. I don't know, is there a way to? It's advancing without me touching anything, so we can back up a couple here. So, and then automatically it can calculate the progression of the it's called the ground reaction force, but that's basically the force line that's progressing forward as you walk, and it can calculate that in terms of where it's occurring on the feet as you walk forward. And I think I don't have the color. Well, here, down there at the bottom, red is the highest pressure, magenta, yellow, cyan. So the grayish colors mean less pressure, and the more vivid colors mean more pressure. So this is an example of using this device for looking at the differences between someone who's wearing one of the more common orthotic devices, which is an AFO, versus not wearing it. And you can look at the voxels or the little boxes and seeing how much pressure is occurring. This kind of analysis would be useful for something like if someone's getting redness or pain in some part of their foot, you could take a look at the pressure patterns to see if it correlates to increased or decreased pressure on the walkway underneath where the person is complaining of pain. Okay, I think, yeah, okay, great. Okay, so this would be an example of someone with left spastic equinovarus deformity, and it's showing that there's poor heel contact on the left foot without the AFO, and I have a picture there of an AFO, and then there's an increasing improvement with heel contact with the AFO, which wouldn't be surprising. But if that person had a lot of spastic tone, and even in the AFO, the tone was pulling the heel off the ground, you could see that in a fairly sensitive way with the use of this technology. Here's an example where two conditions are being compared with and without orthotic devices, left foot versus right foot, and it's a demonstration to show the difference between high pressure, less control, without the orthotic on the left foot, and you see that red box and the yellow box disappear when the person puts the orthotic on. And I think the utility of something like this is more for, well, let's try different styles of AFOs and get some idea of which one works better or maybe has a more normal-looking pressure pattern on your foot, and then have them walk up and down the GAITRite walkway to see what changes occur. That sounds better. Okay. So to go back to the idea of therapy principles, I think we need to define the effects of the injury that occurs as precisely as possible, develop a practical therapy program, and I always emphasize practicality when I talk to therapists and talk to families. It's got to be something that people can do and want to do, and do it on a consistent basis. And this gets back to what Dr. Levy was just talking about, the importance of the dose of therapy and the importance of giving enough therapy on a consistent basis. And the analogies I like to use for kids are, it's like brushing your teeth. You know, you do it automatically every day. You don't think twice about it because you know that if you don't do it, your teeth are going to fall out or you'll get cavities. But you don't see, your teeth don't fall out after a couple of days. It takes a pretty long time for them to get that bad. Well, with respect to doing therapy consistently, you may not see any difference if you do the therapy consistently or you don't do it consistently, at least initially. But over time, there are definite either negative effects if you don't do the therapy, such as increased muscle contractures and loss of range of motion, and hopefully benefits if you do it on a consistent basis. These are just some of the things that we already talked about in terms of the effects of injury on the motor function, and we've gone over those before. Doing exercises, these are just pretty basic things to try. Stretching and range of motion, I think, again, that's what I call a low-tech and boring intervention, but it's still the bedrock of treating spasticity, and I think a lot of the motor problems that people have, you have to do your stretching and your exercises every day. Myofascial and joint mobilization techniques are things that therapists are using. This is basically therapeutic massage, but done under very specific, in very specific ways, and this could be useful to enhance someone's gait pattern, and then using active assistive and active resisted strengthening exercises to get stronger because these muscles are going to be weak. And the thing that Dr. Levy mentioned, co-contraction, which means two muscles are contracting, basically fighting each other by contracting at the same time. Usually when you move, one muscle will relax, one will contract, then they'll trade places. And that's why you can actually move joints back and forth. One of the things that goes wrong with spasticity, both from brain and spinal cord injury, is that the muscles don't know when to share, when to relax, when to contract. And it's also one of the reasons that we treat these muscles with something like Botox. So if one muscle is contracting or over-contracting when it shouldn't be relative to the other muscles, so a good example would be the hamstrings and the quadriceps muscles that both act on the knees during gait. You dampen one, the one that's contracting too vigorously at the wrong time, to allow the other muscle to contract and do what it's supposed to be doing. And then doing the exercises is important. Making it relevant, this is continuing some of the comments that have been made by the previous speakers, and especially what Dr. Levy just mentioned with his evidence-based behavioral training model for his Botox project, that you get much bigger bang for your buck if the patient perceives a functional benefit from what they're doing. If someone wants to drive a car and there's a steering wheel as part of their therapy sessions, and they're moving their arms up and down so that while they're holding on to a steering wheel, that is a much more motivating way to do shoulder stretches and elbow stretches than having this lever that they have to turn up and down with no connection to what would be perceived as a real-world activity for them. Okay. So these are just some of the areas where, as you talk with your therapist, think of specific activities that are functionally relevant to your situation, so that the training that you do becomes more focused on things that you want to get out of it. Okay. I think in the interest of time, I'm not going to spend a whole lot. I'm not going to really be talking about braces and equipment today. I just wanted to show you some pictures of some of the equipment things that we use. I'm not going to be talking about you use this AFO under this circumstance and that under that circumstance. I'd be happy to answer specific questions, though, either after the talk or during our question and answering sessions later. We don't use these, by the way, at the Kennedy Krieger Institute, although they're probably just as good as the ones you get today, because they're providing ankle stability in a side-to-side fashion. I just think they're probably harder to put on. These are just some aids to therapy. I think one of the things that is interesting, and you may hear Dr. McDonald talk about something like this later today, is treadmill exercises and power devices where you can actually stimulate the lower legs in a passive way and do a lot of repetitions, a lot of practice, and does that in some way change how the central nervous system, especially the spinal cord, will respond to injury, especially over the long term? And will you get increased function as a result of that? And this is one of the principles of the kind of research that Dr. McDonald is doing, and I think is going to be one of the very interesting things that we're going to be learning about in the next 5 years. Okay, these are just some pictures of some pediatric AFOs, and I'm just going to go through some pictures now. This is a long sitter that we use for children who have tight hamstring muscles. Basically, we sit them down with their legs stretched out and force them to watch half an hour of cartoons on the TV while their ankles are being stretched. I mean, knees are being stretched, sorry. These are 2 walkers. You all know about walkers. This is a gait trainer that we use in pediatrics. It's basically a supported walking device on wheels. Here's a mobile stander. This is a supported stander which you can hook up over a treadmill and then do walking exercises on the treadmill. And there is actually starting to become some research that's coming out now, treadmill training with partial body support. This particular article is about cerebral palsy. 10 children, 3 months of treadmill training, 25 minutes per session, 3 times a week. Again, this idea of coming up with an optimal dose, and probably more than what's currently paid for by insurance. And these researchers did report clinically relevant improvement in 6 of 10, in walking in 6 of 10, and other motor abilities in 8 of the 10 subjects. Thank you very much for your attention, and we'll have your questions later. Where did Chitra go? Break time or not? One more talk? Not yet. Okay. Thanks a lot.
Any questions for Dr. Pidcock?
Yeah.
Any place where there's a picture of the harness used over the treadmill?
Was that an answer to his question? Yeah. Okay, so the Miami project, so if you type that into Google, you'll probably find some nice pictures, and I think that system's called the Light Gait system, LITE-gait. So if you also type Light Gait into Google, you'll probably find some harnesses. Yeah, over.
Where does foot drop fall in here?
So the foot drop is basically one of the problems that you're going to have with weight acceptance and initial foot contact. So AFOs, ankle-foot orthoses, are pretty much used to prevent foot drop. And there are a number of different kinds of AFOs that people use for that. And you really have to see the individual patient to figure out which one's optimal. And I think something like the GAITRite will help be more precise with our decision making.
All right, Jim Bowen is going to talk to us about some other stem cell transplantation.
Well, this talk will take you from the very practical treatments of rehab that can't hurt anybody to probably the most radical and dangerous treatments that